Hi, I'm Tracy Barr. I'm a physical therapist in Houston Independent School District. Today's PowerPoint presentation is about seated learning positions. Ideal positioning to encourage active engagement or participation in educational activities at home should consider the child's ability to hold the position with the least amount of effort. A child with severe physical disabilities often requires adaptive seating equipment to help reduce physical demands from the child while they're seated. That way they can focus more on their schoolwork instead of focusing on staying upright. Ideal position while seated, 90-90-90, refers to your feet resting flat on the floor or on the wheelchair foot plates. Your ankles are dorsiflexed to 90 degrees. Your knees are flexed at 90 degrees. Your hips are flexed at 90 degrees. Both arms resting comfortably on the desk without causing the shoulders to shrug. 90-90-90 reality is that some of our students may not be able to achieve this position due to a lifetime of complications from their specific diagnosis, such as tighter muscles, a flexible skeleton, often with flexion or extension contractures of the hips, knees, and ankles, abnormal curvature of the cervical, thoracic, and or lumbar spine, painful joints, compromised skin, compromised sensation, and decreased mobility. By forcing our students into unnatural positions, we set them up for unwanted pressure and pain, leading to contractures or pressure sores. So why should we ask our students to sit in an upright, uncomfortable position all day? The right of this slide shows the stages of pressure sores. It initially just starts out as some redness on the skin that won't go away. And if the student isn't moved, then the pressure sore can get worse. Pressure sore prevention is actually very simple. Because they can start to form just after a few hours of immobility, repositioning the student frequently is the most important part of prevention. If your student is bedbound, you should change their position at least once every 2 hours. If the student is chairbound, they should be repositioned at least every hour, and if possible, every 15 minutes. The changes in position don't have to be huge. Just the slightest change can help take the pressure off of that area that is beginning to turn into a pressure sore. Repositioning options depend on the student's specific wheelchair. Some wheelchairs will open and close the seat angle, and that helps to accommodate the hip range of motion. If you have a tilt in space feature, that's awesome. It helps the whole student move their entire body weight off of one location and shift it to another. You can change the armrest height to allow the arm to be parallel to the floor for improved blood flow to the hand and wrist. This can also decrease impingement or subluxation, dislocation of shoulders. Change the height or length of leg rest to accommodate for contractures or tightened muscles. And remember, asymmetry is good when it's needed to accommodate a less than perfect posture. Common wheelchair seating and positioning problems and how to fix them. Why does your posture matter? Because improper positioning can lead to several other problems, including difficulty breathing, problems with swallowing and risk of aspiration, which means breathing in foreign objects like food or water so it goes down the wrong pipe, poor digestion, urinary tract issues, lessened ability to use arms for self-propulsion in wheelchairs and other tasks such as school activities, because the arms are actually needed for balance instead of action, risk of tipping the wheelchair, and it also impedes socialization with others. Posterior pelvic tilt means when your pelvis is tipped backwards and your torso is tipped forward in a slumped position so the head looks at the floor. The problem with this C-shaped curve, it can create restrictions in breathing and voice projection. Abdominal pressure can lead to constipation, reflux, and increased risk of urinary tract infections and other bladder problems. Plus, the downward position of the head can make you more susceptible to choking and aspiration. It can also interfere with socialization as you can't look upward for activities or when you're talking to other students. Solution ideas for posterior pelvic tilt. If the pelvic tilt is correctable or fixable, there are products that you can use to help adjust the position. One easy solution is half of a lumbar roll or a pool noodle. Attach it behind your pelvis in your low back to help keep you in proper position while seated. A 4-point pelvic belt or safety belt can also help with maintaining good posture. Anterior pelvic tilt. Anterior pelvic tilt means your pelvis is tipped forward toward your knees and your back is often arched and your gaze looks up at the ceiling. The problem with this is that the excessive spinal curve creates problems with your digestion and bladder, leading to constipation and UTIs. The hyperextended neck can create difficulty swallowing and increased risk of aspiration. Also, the upward eye gaze can make it hard to engage with others and enjoy communication with them. Solutions for anterior tilt. A correctable tilt can be improved by using positioning aids. An anti-thrust cushion or wedge cushion is positioned with the smaller end of the wedge towards the back half of the wheelchair seat and the thicker half of the wedge under the knees at the front of the wheelchair seat. This helps tilt your pelvis backwards into a neutral position. Using a 2-piece safety belt for extra support will also help. Pelvic obliquity means one half of the pelvis is higher than the other instead of it being even. You may lean to one side or appear to be sitting crooked. Your spine is curved due to positioning, which causes pain, and one side is receiving more pressure while seated, and that can also create pain and pressure sores. Solution ideas for pelvic obliquity depends upon whether the obliquity is correctable or if it's fixed. If the obliquity is in early stages, an adjustable quadrant cushion can help. This type of cushion features 4 individual quadrants that can be inflated to accommodate the obliquity. Another option during the correctable phase is to use a hip belt. Secure it at the 90-degree angle to counteract the obliquity. If you're looking for one simple solution, a wedge can be used with both correctable and fixed conditions. The built-up side, put it underneath the lower half of your pelvis if it's correctable. This will help keep your pelvis equal, level, and balanced. If you have a fixed obliquity, place the built-up side under the higher half of your pelvis. This will reduce the amount of pressure that you have on the lower part of your pelvis and give you more stability than a flat cushion. Notice, the information in this presentation is not student-specific. If you have questions about a specific student's seated learning position, please contact the Houston ISD Physical Therapy Department. Thank you again for watching this presentation.